New Mexico. He spends his free time exploring new recipes, enjoying live music, and taking day trips around New Mexico, but mostly enjoys being an active homebody with his orange cat. I will also have the pleasure of introducing Emily Kaltenbach when Pauly's done, and we might hear a funny story about his orange cat. I guess they have specific things that they're special at. So with that, I'll let Pauly take over and we'll enjoy a little bit of information from our health department. We're very, very lucky to work with. Thank you all for attending. Pauly.
Awesome. Thank you, Kim. So again, my name is Pauly Maldonado. I work in the Hepatitis and Harm Reduction program with the Department of Health. And yeah, I guess I'm pretty much just going to give you all an overview of what we do as far as the program goes. And any questions you have, if you want to throw them into the chat, I'd be more than happy to answer them either along the way or afterwards, whatever works best. Let me go ahead and start sharing my screen.
Heck, you haven't even unpacked.
You want to
try clicking on slideshow.
Oh, there it is. It's hidden. Sorry about that.
No worries.
There you go. Great. Okay, cool. So yeah, again, any questions you have, please go ahead and just ask them or put them into the chat. So the start of the harm reduction program here in New Mexico was because there was a seroprevalence study done back in the 90s that happened between 1994 and 1997. And they tested, I believe it was just over 1,000 people. I think it was 1,002 or 1,003 people. They were doing testing with them, and they found that of those people, 82% of them came back positive for having hepatitis C. 61% came back positive for hepatitis B, and 0.5% came back as HIV positive. So because this happened, it really alarmed legislature to go ahead and put a move on it, right? So they found that of the people that they were testing, it was all people who were living on the streets or had some sort of homelessness experience going on. So they kind of went around, I believe Albuquerque was primarily where they went around, but I think they also went up in northern New Mexico as well. So obviously because of this, you know, it created a really big change as far as harm reduction goes across the country. New Mexico has become one of the kind of, I don't want to say spearheading, but we've become a really amazing program for a lot of other places around the country to look forward to. I will also acknowledge that New Mexico is one of only 2 states that have harm reduction access be a right rather than a privilege. So it's us in Hawaii, but every other community that you come across around the country is going to have like more specific rules. It's going to be either like city organized or county organized. But we're one of the ones that are pretty lucky that we get to go from like the top down. So there's been a lot of change in harm reduction recently. For a very long time, heroin was the #1 choice drug that people were injecting. I will let you all know now it's very hard to find heroin here in the States. There are some places where you can still find it, but it's not as prevalent as it was in years past. When I was growing up, it's not as big as it was back then. And fentanyl really took over like within a really short amount of time as well. It's probably within almost like overnight it kind of happened. During 2021, we really saw a really big decrease with people who were exchanging syringes with us. So we have always been a syringe exchange program. Currently, we are now in a syringe access program, meaning that people don't have to have syringes in order to get them from us, right? So people can show up, we'll give them like a starter pack, what we call starter pack, 30 syringes. Plus, if they did bring anything else, we'll give them that as well. Fentanyl is a lot more shorter acting. So back in the day when people were using heroin, they'd have to inject, you know, maybe 2 or 3 times a day to keep from getting sick or to keep, you know, just from being out of comfort. Nowadays, people are smoking or snorting fentanyl a couple times an hour, kind of just to keep that high going. Fentanyl is a lot shorter acting high, but it's a lot higher of a high. So people don't need to use as much of it, which is why people started using it both inhalation and through snorting. it's kind of interesting how that happened because harm reduction's always been like a community-based organization. You know, it's nothing about us without us, meaning that we've always talked to people who have been using, you know, consistently, people who have been using in and outs, people who are in and out of recovery is what I mean. So because fentanyl is a lot shorter acting high, people need to use it more often, but you don't have to use as much of it. So that's why people are using a little bit different way than they were before. Um, and back last year, HB 52 was passed, which allowed us to really begin handing out smoking inhalation supplies. Um, before this amendment was passed, we couldn't give out anything that could check drugs, right? Like anything that was deemed a drug checking tool was illegal. With that amendment, it helped us be able to give out both fentanyl test strips, and we're also going to be able to start doing adult friend checking now, which is really exciting. We're going to have that training probably in a couple of weeks, and then we're going to hopefully start taking samples from the community once the new year starts. And obviously, you know, reaching different populations is always an ongoing success for this program. You know, it's again, we hear a lot from the community about what's needed. It's not coming from the governor's office or from us, you know, sitting in desks being like, okay, this is what's necessary now in the community. People are talking to us. You know, we've always welcomed the interaction from people, and really just the knowledge that people have, you know, amongst themselves. That it's very important for us to know what's going on within our community. So a little bit of overview of harm reduction services. So again, syringe exchange is kind of like what it was primarily. Right now we have syringe access, again, with safer smoking stuff and safer inhalation supplies as well. We provide a lot of overdose prevention training also. So I've been doing a lot more trainings in schools, which has been kind of new for me because I've always kind of talked to people who are a little bit more in the know of what harm reduction is, what substance use is. So me kind of going into like trainings now, it's interesting to find the conversations that we're having with more people, you know, like uh, destigmatizing usage, demystifying fentanyl, you know, it really supporting fentanyl facts, and just kind of creating a little bit more awareness. You know, I think the biggest thing for me is like whenever I do whenever I do the overdose prevention training, is I want people to make sure that they're comfortable responding to someone. I don't want someone to feel like, oh, I can't give this person rescue breathing because then what if I overdose myself by putting my mouth onto theirs? That's not something that could actually happen. You know, you probably won't even get high if someone has fentanyl on their lips and you give them mouth to mouth. So just, you know, clearing some of that stuff up has been really interesting for me. Um, we also give out syringes to people who use insulin who can't afford them, or if their insurance doesn't cover them for whatever reason. We do a lot of other wraparound services, especially surrounding sexual health, which I think is really important. So STI testing, we've made syphilis testing a requirement for our harm reduction programs over this past year, just because there's been a lot more prevalence within syphilis within the community, you know, the community at whole, not just people who are using substances, but, you know, babies who are born with syphilis nowadays, it's really high up there. We have a really high rate here in New Mexico, one of the highest in the country. So we're really trying to fight that as well. We do a lot of hepatitis testing and vaccinations, which is really amazing. We also have Andrew Knox, who is part of our team. He's the viral hepatitis coordinator, and he's done a lot of work with Project Spicy. I'm sorry, not Project Spicy, Project Heat. Project Heat. It's this really cool program where for 6 months people can sign up for this quote unquote insurance, and you can get all the treatment and testing done. But not only for hepatitis, any other like ailments that you may have going on during that 6 months, you can also have that taken care of as well with the same money. So really awesome program that we have available. And most places that offer syringe access services also offer wound and access care, because most of the places are either a public health office or there's some sort of other community-based organization that offers medical services. So here is a couple of graphs showing, excuse me, showing how people were changing their behavior from injecting to smoking. So again, we saw a big decrease with syringe exchange services. So I think the highest that we saw was probably about 12 million syringes being exchanged around 2019, 2020. 2021, that went down to about 8 million syringes. And in 2022, it went down to about 4 million syringes. So really, really huge decreases in the amount of syringes that were being exchanged or brought back to us that we were giving out as well. But again, it's because people were using it in a different way, right? People were knowing that like, oh, you only have to smoke a little bit of the fentanyl pill in order to get the same kind of high, in order to feel well, right? So people didn't have to go to injection to feel that same sort of normalcy, if you will. And again, the changing of that law really expanded our harm reduction access, meaning people-wise, just because we were able to cut off the age restriction. Before, people could only, you had to be 18 or older to access harm reduction services. Now anyone of any age can come to an exchange and just kind of learn more about it, you know. And that's really helpful, especially for younger people who have older family members, siblings who may be using. They're able to access Narcan without having to go like through an adult in order to get that to their accessibility. So harm reduction services overall, again, I mentioned wraparound services before. I kind of like to think that harm reduction centers can be kind of almost like information booths. You know, people kind of come to us to seek out, you know, food boxes, clothing, medical services, etc. And over the past year, we have given out over 12,000 referrals in any of those kinds of arenas, if you will. So again, assistance with food support, substance use treatment, medical services, clothing, housing. Over 2,000 intensive active navigation services were given out as well. That's going to be a little bit more like in-depth, like almost like case management kind of stuff, right? So yeah, it's really incredible to see like what we do as harm reduction. Again, I've been doing this for a very long time, so it's really awesome to see kind of like how it's progressed within, you know, even just within the past 5 years. We've really made it to be more accessible to a lot more people, and not just because they're using substances. And again, we recognize that syphilis is happening a lot more often. There was a lot more prevalence, so it just made it more accessible for testing and treatment. So OD reversal services, again, not every overdose is fatal. So, you know, overdoses do happen more often than once. They can happen more often than once. So again, with Narcan distribution, we have over 60 sites around the state that you can access Narcan from. That's going to be both public health offices as well as community-based organizations and other sites like schools, that sort of thing. When I tell people at schools about Narcan, it's kind of like almost the kids themselves definitely have a chance of ODing if they're using, but they might more often come in contact with like a coworker or like a guardian or a parent of someone, like a student, who might be overdosing instead. So we just make that clear as well. And again, we also overdose prevention training for law enforcement, LEDI. So we offer them training. They offer a lot of other law enforcement around the state training as well, which is really incredible. Josh has been doing a lot of work with them for a big number of years. And again, we provide fentanyl test strips to those most at risk, meaning mostly people who are already kind of involved with accessing services. We don't necessarily give as much to people like to different agencies who just kind of like want to have them on hand. We want to make sure that they're going to be actually used when we give them out. So same thing with Narcan, you know, we don't want Narcan to just be given and put on a shelf somewhere. We want to make sure that it's actually going to be put into the hands of people who actually need it. So again, I mentioned the behavior of people who have been using in the past. That behavior has completely changed. You know, not to say that not anyone is injecting fentanyl, but definitely not as they were with heroin in the past. So fentanyl was created back in the 50s and 60s as an intravenous anesthetic for cancer treatments. Back in 2011, there were over 40,000 overdose fatalities in the country, and less than 3,000 of them were associated with any fentanyl at all. As you can see, that number dramatically jumped within 10 years. More than 70,000 of the over 106,000 overdose deaths that happened had some sort of fentanyl association with them. So huge increase in percentage of people who've been using. And it's also being manufactured illicitly, right? So it's not like people are buying these pills from a pharmacy and selling them to friends that way. These pills are being made counterfeitly, and it's, you know, you can't test to see the quality and purity of the strength of these pills. So each batch can be different from the last. We always recommend people do a sample, you know, so you can always take more of a substance in, right? But you can't actually take it out of your body. So, you know, smoking a little bit at a time. We used to call it test shots, but again, now that people are smoking and snorting more often, we're just having to change up the language a little bit. So smaller samples, you can always do more of a drug later on if you absolutely need to figure out which high is best for you. People also crush them up. I don't see that very often, but people can do that as well. Xylazine is something that's really common on the East Coast right now. Xylazine is very common in combination of use with fentanyl, not meaning that people are using them both simultaneously by choice. They're using, like, say, one pill itself will have like xylazine and fentanyl in it. Again, xylazine is not an opioid tranquilizer. Sorry, it's not an opioid, so Narcan won't do anything against it. It's a veterinary tranquilizer, so sort of a similar effect to ketamine, if any of you have any experience with that. Rapid onset after consumption. So again, with xylazine, it's kind of like people have said in the past, xylazine gives fentanyl legs, meaning that it kind of just really extends the feeling of it, but it's not an opioid. So some people are like, well, what if someone's overdosing and I don't know if they're on xylazine or not? It's like you can always give someone Narcan. You know, it's better to give someone Narcan now and kind of figure out if that's going to work, because if they have consumed both an opioid and xylazine, at least the Narcan will work against the fentanyl or whatever other opiate is in their body, right? And again, rescue breathing and client education is really key to response. Rescue breathing, you can keep someone alive for hours just by breathing for them. If you don't have access to Narcan, if someone doesn't want to call 911 for whatever reason, you can just breathe someone to keep them alive that way. So here's a little bit more data showing, excuse me, deaths over 12 months, right? So the data that we have for 22 isn't complete just yet, but as you can see, over the past 5-6 years, overdose deaths have occurred a little bit more frequently than they had in the past. And all of these are different drug types that have been associated with overdose deaths as well. Again, all of these points are different over 12 months. Drug types are not mutually exclusive, so people can be on multiple substances at once while they pass away from an overdose. So again, you can see fentanyl really took a huge rise in 2020. Heroin took a really big dip in 2021, again, just because of the accessibility. Heroin is really expensive to create. It takes a lot of time to create, you know, because it's made organically from plants. Fentanyl is made in a lab, right? So people can make it as often as they need to, which means that it's a lot cheaper and it's a lot more accessible to a lot more people. So Narcan distribution has become a really huge part of what we do in harm reduction, not only lately, but over the past, 25 years, like I've mentioned. So far this year, we've given out over 25,000 doses of Narcan. Again, that's through different agencies and through different public health offices. Over 3,000 people have been reported okay after they had some sort of overdose, after they've been given Narcan. So again, not every overdose is fatal. And we always want to make sure that we collect data from people who have reversed an overdose on someone else, right? I think it's really something that people don't realize is we give Narcan for you to use on someone else. We don't give it for you to use on yourself. So it's something that, just again, more chats with other people around that. And then again, adulterant checking, very lucky to start having that be available for people. So I believe we're going to have about 4 or 5 sites around the state where people can send in a sample of a substance that they have, and within a week they'll get the results back to see what's exactly in it. Really, really awesome stuff that we're doing with that. So with adulterants being able to be created and less stable and predictable drug supplies, again, like you're not able to check the purity and the quality of the strength of substances, which is why they're always it's more dangerous now. Doing drugs is more dangerous now than it ever has been actually in the past. When people were only using heroin, at least we knew what we were kind of up against. Whereas like now, with these counterfeit pills, sure, there's fentanyl in it, but what else is in it as well, right? So we just want people to be a little bit more aware of what they're putting in their body, but also the different tools that are also accessible to them during this time. Again, you can always do more. So it's really important to kind of avoid that potential dangerous dose, right? So always using a little bit. You can always use a little bit more if you need to achieve a certain kind of high or non-sickness. And again, a different response that we're having with the community. Everyone's been asking us about Narcan. I've been getting emails from the smallest school districts in the state on how they can access naloxone from us. And again, it's really interesting to see just the destigmatization kind of go on right in front of people's eyes. Like as they're talking, you can see them kind of like start to almost backtrack on what they were just talking about once they realize, behaviors change and people need help regardless of what their living situation is or what their drug use is as well. People aren't defined by their drug use, right? So when you say if someone goes out right here in front of us, right? If someone were to go out right here in front of me, I'd probably give them Narcan first because I know that they've been at least breathing more recently. if I come across someone who's maybe passed out like at a bus stop or something like that, it might be safer to give them a couple of rescue breaths first before you actually give them the Narcan. I say this because people die from overdoses because of lack of oxygen, right? So the longer someone goes without oxygen, the higher chance they do have of it becoming fatal. Rescue position is really something that you can do to help someone stay alive if you have to leave them alone for any amount of time. If it's like to go run to the neighbors to grab Narcan, for instance, you can put them in the recovery position, so that way, in case their body decides to vomit while they're not around, meaning consciously, that at least it'll come out of their mouth instead of them choking or drowning on it. We always advise people call 911 because whenever you give someone Narcan, I personally wouldn't give someone Narcan maybe more than 3 doses. If you give someone 3 doses, that's a pretty adequate amount to give anybody, no matter on like the tolerance, no matter on their size or anything like that. 3 doses of Narcan is a really great amount to use on anyone. If if someone isn't responding after you've given them 3 doses of Narcan, it might be a different medical emergency that you're dealing with, you know? So that's why we always recommend people call 911, just in case it's something that's out of their control.
Hey, Pauly, sorry to interrupt. Just want to let you
Yeah.
know there's about a minute remaining.
Okay, I'll try to kick it into high gear. So again, we meet people where they are, not only physically, but also mentally. Not everyone is wanting to access new stuff. You know, people are kind of like stuck in their ways, meaning that usage is very habitual. It can be very spiritual as well. So people don't really like to change what they've already been doing. Oh, that's my last slide. So I guess it makes sense. But you know, we always want to make sure that people have access to whatever they need, you know. And again, even if it's just kind of like talking about like, hey, I have an abscess, like what can you do about it? Using a hot compress, you know, if they can access antibiotics at an urgent care, something like that, that'd be great. But we just, you know, it's really interesting to work in harm reduction and to see the differences that we've had ever since I started. You know, it's really incredible to see the welcoming that it's had within the community. So but yeah, I'll end that right there. Josh Swalchik is my supervisor, so that's all of his information up top. And then we also have a really awesome team of people on our team. Kelly Watson's become a really amazing asset with communications. And the only person missing all that is Phil Feudy. Phil Feudy is going to be our person who's doing the adulterin checking. So thank you, everyone.
Thank you, Pauly. That was really good. I'm always impressed with the work that you guys are doing there, and there's always new information. Thank you so much. Hold your questions. We will come back to them, and I'm going to introduce you can also put your questions in the chat, but I want to introduce Emily Kaltenbach. She is the Senior Director of State Advocacy and Criminal Legal Reform in the Office of National Policy. She for the Drug Policy Alliance. She leads the DPA's state advocacy efforts, and especially efforts to decriminalize drugs, divest from punitive police responses, and build health-based alternatives. Emily previously worked in DPA's New Mexico Policy Office, where she was instrumental in passing marijuana legislation, reforming the state's asset forfeiture law, a model for the rest of the country, and helped start the second law enforcement assisted diversion program in the country. Before joining DPA, she worked in New Mexico implementing rural county-based health centers, helping reform the state's long-term care system, and setting the stage to implement federal healthcare reform in the state. She was born and raised in New Mexico, rural New Mexico, graduated from Beloit College with a BA in sociology, and later completed a master's degree in health administration from the University of Washington School of Public Health. With all those accolades, what I can tell you is that Emily is very down to earth and understands stuff that's happening on the ground. Emily, we also hope to hear a little bit, maybe a tiny update about what happened in Arizona at your meeting last week. So with that, I'll turn it over to Emily, and thank you so much for joining us. Everyone, welcome.
Thanks, Kim. Thank you so much. I'm so excited to be here. I see so many familiar faces, and I'm excited to meet new people. There's actually someone here who I went to elementary school with, so that is so exciting. Anyways, and folks who joined us in Phoenix last week. So I'm going to share my screen. If you'd bear with me for 1 minute, would you let me know which screen you see? Because I have two.
We can see your slides.
You can see is it do I need to make it in the full view, or is it?
Yeah. It's not in the full view yet.
But it's a beautiful color. I need to know what that color is. It's like coral. Fantastic. There you
Those
go.
are our new colors. I'm so excited to, we just went through rebranding, but anyways, I'll do just a quick introduction. New Mexico is my home and my heart. And so I'm going to spend a lot of time talking about sort of the policy work we've done in New Mexico and what we would like to do. As Kim mentioned, I don't like that it says I previously ran the New Mexico office because I'm still working in New Mexico. So I just want to make that clear that New Mexico in my state-based advocacy work is still very important to Drug Policy Alliance and to the work we do. So I'm going to just start out because I know some of you don't have any idea who Drug Policy Alliance is. And for those who do, bear with me, but I think it's important to just sort of share who we are. We're a national organization. We started in office in New Mexico in 2001. And so we've been working in drug policy reform here and elsewhere. We have a state office in California and in New York. We also have a federal office, but we are working with partners all over the country. We're working to end the drug war, repair its harms, and build a non-punitive, equitable, and regulated drug market. And we can talk about what that means in a little bit. I think we all like videos and like different visuals. I'm going to try to play a really brief little intro to who we are in our new branding. Let's see if it's going to work here.
People deserve a world and future shaped by love, not war. For far too long, the drug war has been used to pin us against each other. Our communities deserve better. We are the Drug Policy Alliance. We may look different, but our fight to end the drug war hasn't changed. We're clear about the future we need to build. We're building a future where people are part of our community, regardless of their relationship to drugs. We're building a future where bodily autonomy is protected and respected. We're building a future where drug policy is grounded in health, equity, and human rights. We will end the drug war and build a better future together, period. Join us.
So I think the question is, what does this mean? And what are some of our policy priority areas? Most importantly, it, as you know, Pauly was talking about, is really developing policy that is driven by people who are most impacted and is driven with the core goal of saving lives, compassion, and science, and reducing stigma. So these are our core priority areas. As Kim mentioned, decriminalizing drugs and investing in health services. When I say decriminalization, the definition of decriminalization is really taking a criminal penalty for drug possession and making it a civil infraction. And so Oregon was the first state to do this in the US. The first and only so far, and there you get a citation and potentially a fine, depending on whether you complete an assessment. But really, most importantly, it invests dollars back into the health system for addiction services. Harm reduction is at the center of the Oregon program. If you have questions about Oregon, because I know it's been in the news a lot, I'm happy to chat about that at the end. I'm not going to go into detail now, but a huge portion of the cannabis revenue is reinvested back into services. And so a network of community-based organizations, housing, harm reduction, treatment services are all being funded, and people are not going into the criminal legal system. They're being treated like humans in the health system. And we're working in other states around the country. Right now, I'm actually working in Minnesota on legislation there. We're looking at what other states we might do ballot initiatives, because it could be either through the ballot box or through legislation. Lots of other states have also introduced bills to decriminalize and exploring different models. Overdose prevention centers. I might spend a little bit more time on that today, but these are places where people can go with their pre-obtained drugs to use in a safe environment. These are also, though, very much bridges to other social supports and services. And New York City is the first place to have implemented overdose prevention centers, even though these have existed all around the world for over 30 years with really great evidence. This is something that could work in New Mexico, but we have to look at it from an urban sort of rural perspective, and what are some other really innovative harm reduction services that we could look at. Community reinvestment, like I said, investing back into community. We can't just change laws. We have to make sure that the money's going to support people. Ending drug war civil punishments. This is an exciting new area for us. This is about looking about how the drug war has its tentacles into all aspects of everyday life. So whether that's housing, whether that's child welfare, employment, immigration, we know when people are enmeshed in the criminal legal system, that haunts them for the rest of their lives. And so looking at things like, making sure in some states that if you have a positive drug test, you don't lose your public benefits. Drug testing for employment, for example, especially around marijuana, which is now legal in many states around the country. Looking at how children are taken away from parents because of drug use and not having informed consent about testing. Those are all things, or not even being able to get your housing because you either have a criminal record or you're currently using. So I'm excited about DPA's focus on this, and we can talk more if people have questions. Legalizing and regulating marijuana the right way. We're doing this because of racial justice. We're doing this to reinvest back into our communities for reparations. It's not to create a legal market for a bunch of people to get rich. It's about really addressing the issues there, making sure records are expunged. This is very difficult because we know that there's lots of money involved. And so DPA is really trying to be a voice of lifting up why are we legalizing and regulating. Legal regulation and safer supply is new to DPA. When I started almost 13 years ago, we would have never said this out loud, but we know, and as Pauly said, the drug market is getting more and more dangerous. And why? Because of prohibition. It is much easier to make synthetic drugs that have adulterants because of prohibition. We're going to continue to see more adulterants as we see policies cracking down on fentanyl and xylazine, because people are going to be using, they're not going to feel safe to access harm reduction services or treatment services because it's still legal, and we need to have safer supply. What that looks like, I hope, is really and must be informed by people who use drugs and people who have lived experience. And then we can't leave behind people who work in the drug trade. So often policymakers will say, oh, well, we don't want to criminalize the users, but we have to go really hard after the dealers. We have to ask ourselves, who are those dealers? Many of those dealers are users. Many of those dealers are dealing because they have past criminal records and they can't get a job in the above ground market or in economy. Many of those dealers are moms trying to put food on the table. And so oftentimes when we go after the dealer, we never go after the huge cartel and the huge dealers, right? We're going after people who live in our community. And so we need to start thinking and talking about what does policy and support look like for people who are in the drug trade, and how do we provide diversion programs, economic development opportunities, mentoring and training, and eliminating the obstacles that keep people from getting good jobs that may not be in the drug trade. I'm just going to go back through a little history. I'm not going to, I know these are really crowded slides, but I just wanted to highlight where New Mexico, New Mexico's really led the way, and thanks to Department of Health in the early days and now for really, making harm reduction a priority, we've led the nation. So when DPA came in 2001, we worked with partners on the ground with Department of Health and others to draft and pass the country's first naloxone access legislation and the Good Samaritan bill 6 years later. Now, all 50 states and DC have made it easier to get naloxone, and 47 states, DC, have Good Samaritan laws. So New Mexico really is leading the way there. In 2019, we became the first state to repeal criminal penalties for possession of all drug paraphernalia. That was done very sneaky, as policy can be done. That was in our decrim bill for marijuana. What we did is we included language in there that decrimmed all drug paraphernalia, not only drug paraphernalia for cannabis. And so that was a really exciting win. And we've seen similar measures being passed in DC the following year. Minnesota actually just passed a pretty exciting bill this last legislative session that decriminalized residue that is contained in drug paraphernalia. So we're seeing these small steps towards a health approach. And as Pauly mentioned, Department of Health led the way in drug checking supplies and making those decriminalized and accessible in 2022. Overdose prevention centers, we have been introducing bills for the last, I guess, 5 years or so. We are continuing to have this conversation. It is a model that may be a great model for certain urban areas around our state. And I'll talk a little bit about that if I have time. The building alternatives to criminalization. So again, how do we might be able to change the laws, but if you're not building a system, then they're not successful. So as Kim mentioned, law enforcement assisted diversion, which is now a slightly different model, but came into place in Santa Fe in 2014. Santa Fe County still has a program. I know there are folks on the call from the MIHO and ARU unit that has, I think LEAD has really morphed into an alternative response unit in Santa Fe, which I think is amazing to have non-police response units on the ground. These are things we should be lifting up around the country. I think Santa Fe is definitely a model for other jurisdictions to look at. We also have $1 million in recurring funding for LEAD programs around New Mexico, and there's some programs in Taos and Bernalillo and other places. We also worked to end the corrupt practice of civil asset reform, which was when law enforcement could seize your money or your car, even if just because they thought that you bought that car with drug money, and you had to prove that you didn't on your own dime and hire a lawyer and get that asset back. New Mexico actually now leads the country in how far-reaching our civil asset reform is. This was done, and I'm going to say very surprisingly, under Governor Susana Martinez. She signed this into law in 2015. And so you'll see sort of the reach and breadth of the type of policy work we do. It's not just harm reduction. It's not just marijuana. It's really about disrupting all the systems that the drug war has created. And I talked a little bit about the civil punishment. You'll get these slides. Uprooting the drug war is our new area. Incredible colleague, Melissa, who's working on that. I'd invite you to look at our webpage on Uprooting the Drug War. I think it's very exciting. Two other quick things I'll note is around building bridges across movements. And as Kim said, wanted to know how our big conference went in Phoenix. It was amazing. So every 2 years, we have an International Drug Policy Reform Conference. People come from all over the country and the world. We had 3 days in Phoenix last week. It was the first reform conference in 4 years. Post-COVID, a lot has changed. We have a new executive director, Cassandra Frederic, who is inspiring and incredible. And I just have the great privilege to be able to work at DPA with her leadership. We're going to be in Detroit in 2025, so mark your calendars. But this was an opportunity to have all these conversations from what should alternative sanctions be? Like if you decriminalize drug possession, should there be civil sanctions, and what should they be? Because we know that's still punishment, right? So if someone can't pay their fine, they end up back in jail because they have a warrant for their arrest. And so sort of thinking through really at a deep level about policy, about how we can build movements across our movement across different movements. So thinking about income inequality and sex work and decriminalizing people, right? Because we know people are criminalized for so many different behaviors, and how can we bring those movements together? We also have a grant program, so we grant dollars back into the community for great work, and we have an incredible Department of Academic Engagement and Research where we're trying to bridge the gap between research and policy. So how much time do I have? Do I have like 5 minutes?
Probably about 3 to 4.
Okay, so next steps in New Mexico, let's bring it home. Again, I'm so committed to continue working here in New Mexico with all of you. There are 3 areas that DPA is prioritizing in New Mexico. One, now that we have legal cannabis, reinvesting those dollars back into the communities. Because right now, all of the state revenue that's acquired from the state excise tax is going into the general fund. So we've been advocating that those dollars need to go back into harm reduction, to prevention, to addiction services, housing, and drug education. Like those are areas we know we need additional dollars. Here we have millions of dollars every year that are going into the general fund. So we're working on how to figure out how to funnel those dollars back into the communities that have been most impacted by the war on drugs, who have been most impacted by overdose, been most impacted by economic insecurity, and are unhoused. That's one. These are not in any order. The second of priority. The second one is authorizing overdose prevention centers. I could spend another 20 minutes talking about that and innovative harm reduction services practices. So we're going to continue to introduce that bill, not this session, but the next policy session, since this is a budget session. And I'd love to build out a robust coalition of folks who want to work in this area, but also who want to come to the table with new ideas around harm reduction strategies. Maybe that's safe supply of opiates, fentanyl, where we know that it's not adulterated or people know the purities. I don't know. There's an incredible program. I don't know, many of you may have seen this, but I think it was in Louisiana, where a mom who has a daughter who has been experiencing chaotic drug use works for a hotline where people can call if they're using and they're alone. It's almost like a phone-based prevention center. And that's, and so they like coach them, make sure they're not behind a locked door. They know if they need to call EMS services because they become unresponsive on the phone. That's really cool. Is that something that could work in New Mexico? I don't know. Something to explore. And then the third area is around defelonizing drug possession. I don't think New Mexico is quite ready for decriminalization. So I think we need to take the first step and bringing possession from a felony to a misdemeanor. That's a huge step because, again, we know if you have a felony on your record, all of those everyday life issues become so much harder. And we need to start addressing the disparity in sentencing in this state. People are going to prison. They're getting a felony on their record for having trace amounts of most drugs here. And so we need to start addressing that and supporting increased access to addiction services and social supports. I'm going to end there. My slides, when you get it, have some information and links about overdose prevention centers. And so I'm not going to go through all of those, but and then at the end is my contact information if anyone has questions or wants to reach out. So thank you so much for that whirlwind.
Thank you, Emily. That was really terrific. This is so fantastic. First of all, that study that you showed, Pauly, that kicked everything off, that Michael Samuel did a long time ago. He was my colleague in graduate school, and I was very excited when he came to work here, and I knew it would lead to good things. We are a leader. We are leading the pack here. Someone asked me recently, what states do we follow? Where are we getting our ideas? And I said, oh no, wait a minute, they follow us. So the work that Emily and the Drug Policy Alliance does is great. And Emily, we'll have a whole session just on overdose prevention services, and then we can maybe have a more in-depth discussion about that. A paper came out today from San Francisco on what's happening there. So let's do that, and I'll have Peter Davidson come talk at the same time. That would be fun. So with that teaser, I will open this up for questions, and you can raise your hand or put it. I'll let Christina monitor the chat.
Yeah, there are a couple of questions in the chat. Running from most recent back, Joyce Runyon says there's a never use alone hotline number that anyone can call. Are you aware of that resource? And Pauly, you answered that in the chat. You said this hotline is a major resource that you promote in your trainings. There was another question. What are the legal issues for accessing marijuana funds at a community level?
That's a great question. So every county and city also get a certain percentage of the dollars, the sales tax dollars, go back to cities and counties. They can use those dollars in any way they want. So again, those dollars are going back into their own local general fund. So I would encourage everyone to reach out to your city council, to your county commission, and ask how those dollars are being used and whether there's a way to appropriate those into your own community-based programs. I think we need to start voicing that both at a state and a local level.
Can I expand on that a little bit? This is Joyce. I'm the one that put that in chat. Because that's a legal process here in our state, and I'm part of a health council which receives grant funding that falls under different guidelines. Sometimes those things are in conflict about what we can use, how we can get those funds. We have several dispensaries in our county, and they have funds that they'd like to give, but since we're also grant funded and those are federal dollars, we have to be very careful how we can access that. And if we do, then do we lose our funding? And so this is a huge issue for a lot of our health councils. And this would be something that'd be great to have a presentation on about, because this is money that can be used to help people here locally. And how do we do that without losing funding that we're already getting to help people here locally?
Yeah. No, I think that's great, Joyce. I'm sorry, I misunderstood when you were talking about the legal implications. I will say that until we legalize marijuana federally, there will always be some of those fears. I will say, though, that we have yet to see anyone be, money taken away because they've received revenue. But I know that that's an area where people are rightfully a little fearful about accepting those dollars, but we haven't seen the federal government come in and charge or take away grant funds or others because of using state-based revenue that came from the tax revenue. But I do understand that concern.
Emily, do you advocate the same kind of advocacy from our local partners regarding the opioid settlement funds?
Yes. And so that is a really funny area because I think there's a lack of clarity on how those dollars are going to be disseminated. I mean, definitely some, a lot of, I think 56% or something went out to local areas. And so, and Phil, I know Vital Strategies is working a lot on that. Those are, I think that's a conversation to have with your local government. The state portion, there's sort of a permanent fund that was created with some of those opioid settlement dollars. And there's a whole question I got a call yesterday from someone saying, who gets to appropriate those dollars? Is it the governor? Is it the legislature? I don't know if everyone's very clear about that yet, but if someone else on this call might have more information.
It's also a potentially great topic to bring back to this group if we can find a key person to talk about. So do send us your suggestions. We always want to hear what you all are interested in hearing about. So both of those are very important. Next question.
Kim, Philip, we can have the folks from Vital Strategies who are working directly on that come and talk in this group. Just let me know if that's something that everyone would like to hear. I know that it's been a big complicated thing all over the place, and they currently just released the 2021 funding, and that was pretty simply divided up a percentage that went to each county. I know that the 2022 and 2023 funding is they used a different formula so that money was able to get to places where it was, by the need, as opposed to just an even split between all the places, so all the counties.
Thanks, Phil. We will be taking you up on that.
There's another question in the chat that reads, do you have specific books you recommend for understanding and fighting the drug war?
I can name a few, and I'm sure other folks have some great suggestions, but, obviously the new Jim Crow by Michelle Alexander, is, I think, a must read of sort of understanding the history and the oppression of certain people in our country because of the war on drugs. Joanne Hari's Chasing the Scream is another great book. Alex Vitale, who's written books about policing, which I think, so that sort of covers different areas. Those would be three I'd start with, but there's so many great folks out there writing about this.
Muting myself. What about that book by Maya? What's her last name? She wrote about the history of harm reduction. In
yeah, Maya Saval. I can never say her last name.
I can't say her last name.
A journalist. I just saw her in Phoenix. She's also works for the New York Times and writes. Yeah, that's a great. Oh, Undoing Drugs. I'm so
Undoing Drugs. Yeah,
that's a good one. Yep.
Savalich or something like that.
Yes, she's great.
It's a really good book with a lot of really good context. All right. Well, at our next book club, I'm not going to announce what our next one will be, but we always welcome your suggestions for these sessions. And if there's no more questions, I am going to put in a plug. I received a notification that the College of Population Health at UNM is having a discussion session about harm reduction advocates who will discuss equity and power imbalances in community academic partnerships. That's us, and it will be held on November 6th. And there is a Zoom registration. You can probably find it somehow, or we can put it in the chat if anyone can find it between now and then. But it should be interesting, and I'll be attending. I have no idea who will be presenting, but I love to hear more about what's happening in the community.
So Kim, I'll be presenting.
Great.
So,
Oh, great.
but they're, I could just share a little bit. They're an incredible group of harm reduction folks from around the country. And so we're going to hear from people in different parts of the country as far as their relationship to research as people who work in harm reduction or who've been impacted.
Okay, I think I actually have the web page, and I'll put it in the chat. I pulled it up, not very planning ahead. But all right, and then we can call it a day. I put it in the chat here for Emily. It'll be great to hear what you have to say. And we always want to maintain wonderful partnerships with all of you. So again, send us an email, let us know what you'd like to hear about, or if you'd like to present on something. We always are anxious to hear from you. Thanks, everyone. Bye.
Thank you all.